All right, I'll bring everybody back together for our final session of the day. This is Inlets. This will be our final anatomic session. So the only difference here is we won't have Dr. Anderson or his development video to start, so I'll just hand the mic right over to.
You guys pretty much heard the developmental stuff that is needed for our atrioventricular septal defect discussion. So I'm going to start with that first, and then we'll go into talk about the tricuspid and the mitral valve and some of the things that can occur within those two groups. So when we looked at this short axis to start off with of the normal heart, I showed you how the aorta is deeply wedged between the two atrioventricular valves, the tricuspid and the mitral valve. So if you look at this, they kind of make a clover leaf kind of a fashion at the base of the heart. And if I bring in a heart that has an atrioventricular septal defect, you can now see the common atrioventricular junction and the aortic root. So you can see that the aorta is unwedged, so to speak. So it is more anterior than it is in the normal heart. So this is, if you want to think about it in kind of an easy way to remember, it's kind of how I used to think about it. This is the clover leaf, and this is like the snowman. So that the aorta is like the head on top of the big atrioventricular junction, the common atrioventricular junction. So I'm going to go through some anatomic details as I show you these things and how we look at the anatomy of atrioventricular septal defects. So the unwedged aorta is one of the things that is common with this. And I picked this heart because the valve is dysplastic, but because of that, it shows the leaflets very nicely. Can anybody else tell me what else they might notice about this specimen? We're going to look at this another day as a hint. So there were bilateral morphologically right atrial appendages. So you can see the pectinate muscles all the way around both atrial vestibules to the crooks. So isomerism of the right atrial appendages. You can see there's the little remnant of what was the atrial strand going across this common atrioventricular junction. So when we look at this common valve, the common atrioventricular valve has 5 leaflets, 2 of which are shared. So this is our superior bridging leaflet. It's shared between the right component of the common atrioventricular junction and the left component. Here's the inferior bridging leaflet. You can see how dysplastic they are, but they are not attached across the crest of the septum. So this is, again, bridging the septum, which is here, half into the right ventricular side and part into the left ventricular side. So those 2 of the leaflets. A third within the right side of the common junction is the anterior superior leaflet. A fourth is the right mural leaflet or the inferior leaflet. And then the 5th leaflet is the mural leaflet within the left component of the common atrioventricular valve. And this shows very nicely how the left component of this common atrioventricular valve closes in trifoliate fashion. So that if these leaflets were adherent across the crest of the septum, this zone of apposition here is what people refer to as the cleft. And it points directly at the interventricular septum. So this just shows nicely how the left component of the common AV valve closes in trifoliate fashion. So 5 leaflets. And this one actually, as I said, is very dysplastic. So if we look at the common atrioventricular junction, in a 4-chamber plane. It's a very beautiful heart. This is the inferior aspect, and you can nicely see the pectinated right appendage, the smooth left atrial vestibule, superior interatrial fold, pulmonary vein. There was a defect in the flap valve at the floor of the oval fossa, some fenestrations. And if we look at how Professor Anderson described the development, we can see that the flap valve formed, but was deficient in a few areas. On the leading edge of that would have been the mesenchymal cap, but because the vestibular spine failed to form, we're left with retention of the primary septal defect, or the primary foramen. So that leaves us with a common atrioventricular valve. So you can see that this is the inferior bridging leaflet, which oftentimes has a lot more chordal attachments to the inferior component of the interventricular septum, and the right component and the left component. So this is the crest of the ventricular septum and the leading edge of the atrial septum. If we look at the opposite aspect, so we're looking from the spine towards the sternum, right appendage, left appendage, pulmonary venous component, and here you can see the leading edge of the atrial septum, the defect at the oval fossa, and here's the crest of the ventricular septum. So this is the superior bridging leaflet, and you can see that it's free floating across the crest of the ventricular septum. And I know you guys are probably calling things with the Rastelli classification. So the most common is the C. A B, I don't see too much. I think I have one specimen. And this one has the superior bridging leaflet equally shared between the left and the right ventricle with no attachments to the crest of the septum. This specimen also had some extra valvar tissue up in here in the subaortic region. So I don't know if it was, remnants of something or another, just remnants of the atrioventricular valve or the cushions. You can see that extra tissue, but it was obviously causing some subaortic stenosis, and you can see the extreme hypoplasia of this aortic arch. So brachiocephalic trunk, left carotid, left subclavian. Here's the arch and the isthmus, where the very short arterial duct joins the descending aorta. So this is descending aorta, and it almost looks more consistent or continuous with the pulmonary trunk, with this isthmus kind of plugging in the side because of the severe hypoplasia. And you can see that there was near hemodynamic interruption. This is a 2-millimeter probe that I can barely push in there. So this is what we would call an AP window type of arterial duct, so very short. But that's a nice 4-chamber view of an atrioventricular septal defect. There are some other characteristics that I would like to point out before we move on to the different types of shunting that you can see. So when we look at a normal heart, we can see the proportions between the inlet from the hinge point of the mitral valve to the apex of the left ventricle. And if I kind of mark it with my probe, I can go to the outlet, and those proportions are fairly equal. So there's not any disproportion between the inlet and outlet dimensions in a normal heart. So when we look at the same dimensions in a heart that has an atrioventricular septal defect, so if I look at the inlet component, you can see where the hinge line of this inferior bridging leaflet is. And so if I mark the apex to that hinge line, and I go to the outlet from the apex to the aorta, you can see that there's quite a bit of disproportion between the inlet and the outlet. And that's secondary to this scooped out component of the interventricular septum. So whether you have a so-called primum type of defect where you have two separate orifices, or you have a complete defect, you will still have atrioventricular septal inlet-outlet disproportion. Sorry, that's what I meant to say. And as far as the conduction tissue goes, while we have this heart here, you can see there's some deficiency in fenestrations of the primary atrial septum. Here's the leading edge of the atrial septum, and here's our mouth of our coronary sinus. So you can see here that there is no place for the atrioventricular node to reside, or no complete area to form our triangle of Koch. So that triangle gets attenuated. So it gets moved to this area here. So the hinge point of the AV valve we can see right there, and that's right where the muscular septum meets the atrial component, or the atrial myocardium. So our conduction axis is going to be pushed inferiorly and located right in this area. And so you'll have a long non-branching bundle, and then the branching bundles will eventually emerge from that long non-branching bundle. So these defects are very variable, and it's well known to surgeons where they have to put their sutures in these defects. I think I mentioned earlier when we were looking at an inlet defect that the long non-branching bundle typically follows along the left aspect of this common junction, or this crest of the ventricular septum. So if we look at the different types of shunting that you can see with a common atrioventricular junction, this is a nice example of a so-called primum type of common atrioventricular junction. This is not an atrial septal defect. It is in the realm of common atrioventricular valves. It's outside the confines of the atrial septum, and, well, it's involving a portion of the atrial septum, but there is still a common atrioventricular junction. So the valvar leaflets are adherent across the crest of the septum, superior bridging leaflet, inferior bridging leaflet, and no availability of shunting beneath that those bridging leaflets. So this case has shunting only at the atrial level, and you can see that the primary atrial septum has a few fenestrations, but it's fairly well formed. So there was a good mesenchymal cap, but the vestibular spine failed to join those two structures with the atrioventricular cushions. So we end up with a common atrioventricular junction. So looking at it from the top, you can see that there is the right component, and here is the left component. When we look from the left side, you can now see nicely the inferior and superior bridging leaflets attached to one another across the crest of the septum. And if I tilt it up a bit, you can now see what people call the so-called cleft, or the zone of apposition between the two bridging leaflets as they attach to the crest of the septum. So when we talked about the true cleft of the mitral valve, it typically points more towards the outlet of the ventricle rather than directly at the septum. And if I measure, even though this defect looks kind of small relative to the ventricular septum, it is still scooped out, and the aortic outlet isn't opened, but you can still appreciate that there is inlet to outlet disproportion, so that the aortic valve is typically supported on this higher end of the scoop of the ventricular septum. And when the valvar leaflets are adherent to one another all the way along this left ventricular outflow tract, that can cause some significant subaortic stenosis. So we can have shunting, as we saw there, at the atrial level. This nice specimen that we just looked at shows us the bridging leaflets, superior bridging leaflet free floating, inferior bridging leaflet here, but with no attachment. And so this in atrioventricular septal defect has shunting that can occur both at the atrial and at the ventricular level. So the blood can go any way around. So this is just a nice complete atrioventricular septal defect, or so-called complete common atrioventricular junction. You can also have cases that have shunting at both levels. And in this particular case, the bridging leaflets are adherent to one another across the crest of the septum. The inferior bridging leaflet, superior bridging leaflet, and this would be more of a Rastelli A, because you can see that there's not much of the superior bridging leaflet that's committed to the right side of the common atrioventricular junction. And it doesn't look like it from the right side, but when we look at the left side, you'll be able to see that these leaflets are adherent to one another. Here's the leading edge of the atrial septum. The flat valve is well formed and intact at the floor of the oval fossa, but you can see shunting can happen beneath these loose tendinous cords and above them. So at both atrial and ventricular levels, but with separate right and left atrioventricular junctions, or orifices, I should say. So when we look at the left side, you can see nicely how the inferior and the superior bridging leaflets were adherent to one another across the crest of the septum. This would be the so-called cleft, or the zone of apposition. And here is our mural leaflet, which is actually a bit small in this case. And this case shows nicely how you can have variation in the papillary muscles. So this one looks like a single papillary muscle, but with two heads dividing it. And when we look at the next case I'm going to show you, will show how sometimes the papillary muscles are closer together within the left ventricle than they are in a normal heart. But you can have variations where you have this little hypoplastic papillary muscle, which is kind of close to this bifid papillary muscle, almost resembling a solitary papillary muscle. This is the only example I have that's close to what I want to try and describe to you. So the Lurie collection in Chicago has two really nice specimens that show this particular pathology. And like I said, it's quite rare. So here is our fenestrated flat valve at the floor of the oval fossa, the mouth of the coronary sinus, and here's the leading edge of the atrial septum. And you can see how in this case, the bridging leaflets have more affinity for the leading edge of the atrial septum. And the cases at Lurie, these bridging leaflets are attached here and here with only a small component of the atrial septum between them. So that in this case, during the cardiac cycle, these leaflets will close with more affinity to the atrial septum, and there's a larger degree of ventricular shunting in this particular arrangement. I wish I had a better specimen, but you can clearly appreciate how this bridging leaflet has more attachment or affinity for this leading edge of the atrial septum rather than the crest of the ventricular septum. So this case is to illustrate more shunting at the ventricular level than at the atrial level. And when we look at the short axis of the left ventricle, the papillary muscles aren't totally intact, but there was one group here and one group here. So sometimes they are a bit closer together on the free wall of the left ventricle than they are within a normal heart. So I know we're going to talk about unbalanced AVSDs in one of the sessions tomorrow, but I'm still going to mention them today, and we will also look at them again. So when we have an unbalanced atrioventricular septal defect, you can see here there's a very large pulmonary trunk. There's our unwedged aorta. And you can see that the right component of this common atrioventricular junction is larger than the left. The atrial septum has been cut so I can lift it away or move it out of the way. There's the crest of the ventricular septum. So when you have a right dominant common atrioventricular junction, the atrial septum and the ventricular septum are typically aligned with one another. So they're well aligned. When you have a left dominant situation, you have atrioventricular septal malalignment. Now, this is a very unusual case in that there's an Epstein malformation of the right component of the common atrioventricular valve. So we're looking at this on short axis so that this is the inferior cable vein. The superior cable vein is coming in here. This is the dominant left component, all of this. And here is the floor of the right ventricle. So this is the superior bridging leaflet. This is the inferior bridging leaflet. And you can see that there is atrialization of the right ventricular wall. And the bridging leaflets are adherent to one another across the crest of the septum, and that this Epsteinoid malformation is plastering the tricuspid valve almost totally around the cavity of the right ventricle. There's some apical component left and pulmonary outflow component left. So just an unusual presentation of a left dominant common atrioventricular valve. But you can see the ventricular septum is here, where the bridging leaflets are forming their zone of apposition, or the so-called cleft, right at the septum. And you can see the atrial septum here, which is totally malaligned with the ventricular septum. So those are just two of the common hallmarks in the differences of the unbalanced type of common atrioventricular junction. Left dominant, you have atrioventricular septal malalignment, and right dominant, you have alignment of the septal structures. This heart is from a cardiac explant, and it shows us an unbalanced atrioventricular septal defect. There was a double orifice to the right component of this common AV valve. And I can tell you it's not an artifact because this component has a little papillary muscle and tendinous cord supporting it, along with tendinous cord supporting the other side of the valve. Here's our interventricular septum and our tiny left ventricle. So you can appreciate that the right ventricle is extremely hypertrophied, as are the trabeculations in the apical component. And the bridging leaflet was adherent to the crest of the ventricular septum. So this was a so-called primum type of common atrioventricular valve or junction with nearly imperforate component of the left component. When we look at the other side, from the spine towards the sternum, right appendage, hypertrophied right ventricle, superior bridging leaflet here, again attached across the crest of the septum, and there is the opening to this small left component. And as we typically see with right dominant or unbalanced atrioventricular septal defects of the right dominant type, there is a solitary papillary muscle that was supporting the left component of the common AV valve. So in these cases, this is essentially a double inlet right ventricle because the majority of the atrial communication or the atrial junction is into the right ventricle. And this is a really true fact when you have an imperforate component of the left side of a common AV valve. So you end up with a double inlet left ventricle, and these hearts can also have a double outlet. This one, I believe, does have a double outlet. There's the pulmonary component. Get into the, oh no, it doesn't have a double outlet. That aorta does come off the left ventricle. And this is just a really interesting case of a right dominant common atrioventricular junction. I only have that one left dominant with the Epstein malformation because they are much rarer than are the right dominant types. So here you can see the common atrioventricular junction. There's the leading edge of our, well, what the remnant of our atrial septum. So you can see the ventricular septum here. So there was atrioventricular septal alignment, in this right dominant common AV valve. You can appreciate that the aorta is unwedged. And when we look at the valve, pulling it apart, you can see that there were separate right and separate left orifices. So the bridging leaflets are adherent across the crest of the ventricular septum. The valve is also dysplastic, so dominant right, hypoplastic left side. When we look at the left valve, there is inferiorly this second orifice, so that this is a double orifice of the left component of the common atrioventricular valve. And I can prove to you that it's not an artifact by looking at the left ventricular side. It is, or did have to be sewn back together because it was improperly opened across the atrioventricular junction. But here, you can see the smaller orifice is supported by its own little papillary muscle and its own tendinous cords. This again shows nicely that zone of apposition between the bridging leaflets and how when the bridging leaflets are adherent to the crest of the septum, you end up with this subaortic stenosis or this elongated left ventricular outflow tract. Some people refer to this as the gooseneck, and you can see how narrow this can get. The papillary muscle supporting the larger component of this hypoplastic left valve is basically giving rise to three little heads that are supporting this larger component of the left AV valve. So just lots of variations we can see in this group. I have an extremely unbalanced connection that actually had a Norwood procedure, and it's a very nice specimen to show that. You can see where they've done an atrial septectomy. They've cut out some of the primary atrial septum. And when we look at this case from the right atrium, there's the leading edge of the atrial septum. That's the left appendage right here that we're looking into. So almost all of this common valve is committed to the right ventricle. This is the crest of the septum. And you can see that there are hardly even any chordal attachments into this tiny left component of this common atrioventricular junction. So extremely unbalanced atrioventricular septal defect, but if you look at the leading edge of the atrial septum and the ventricular septum, it follows suit in that the atrial and ventricular septums are aligned in this right dominant situation. The pulmonary valve has now become the neo-aorta, which we'll look at in a minute. When we look at the left ventricular aspect of this common atrioventricular junction, there you can see the scooped out portion of the septum with the tendinous cords attached almost directly to the crest of the septum. And there was actually, in this case, I believe, a muscular VSD towards the apex. It's been cut through, but very tiny left ventricle. When I put the septal or the apical components back together, there is all we have of the left ventricle. That's where the muscular VSD is. And when we look at the left ventricular outflow, it's quite narrow, but the aortic valve was patent. Right here where they did the DKS, there's the left coronary. There was a bifoliate aortic valve because you can see one of the incomplete interleaflet triangles right there, so the RAF-A. And that's the pulmonary trunk, the left PA and the right PA over here, the ligated arterial duct. And now you can see where they've made the pulmonary valve into the neo-aorta. There's the DKS there that I showed you from the left ventricular side. And you can see where they've sewn the hypoplastic aortic arch, which is this component here, into the part of the pulmonary trunk. And this is a patch augmentation here, and then into the arch. So just a really unbalanced atrioventricular septal defect that kind of went down the track of hypoplastic left heart repair. So when we move on to talk about tricuspid and mitral valve issues, this heart is a nice one to follow what we just talked about. It's hard to show on the short axis because it was open following the flow of blood, and then we glued it back together and cut it in a 4-chamber plane to show the anatomy. And you can see that this almost could resemble a common atrioventricular junction, because if I find the septum, it's actually right here. There's the atrial septum and the ventricular septum is here, but we have a component of the tricuspid valve that's crossing the septum. Actually, here's the interventricular septum. So now I'm straight. There's the atrial septum. But you can see that there is right ventricle over here, and part of this tricuspid valve looks like it's straddling and overriding the septum. So this can be confused with a common atrioventricular junction. So when I cut the heart in 4-chamber plane, here we're looking at the inferior aspect. So you see the pectinated right appendage. That's eustachian valve here, inferior caval vein. Superior interatrial fold, flat valve of the foramen. And there's our atrial buttress and our smooth left atrial vestibule. So we have separate right and separate left atrioventricular junctions. And you can see that the tricuspid valve is quite dysplastic, which we're going to talk about the different degrees of tricuspid valve dysplasia we can see in a minute. So there is the interventricular septum. So this is the inlet to the right ventricle. And you can see that part of the tricuspid valve is supported by a papillary muscle across the interventricular septum and into the left ventricle. So there's tricuspid valve that's straddling and overriding the interventricular septum. Interventricular septum is here, right ventricle is here, left ventricle here, and that's the attachment of the papillary muscle within the left ventricle. So straddling and overriding of the tricuspid valve, which sometimes can be confused with an atrioventricular septal defect. But the hallmark is we have two separate atrioventricular junctions and atrial vestibules, so that the vestibular spine, the mesenchymal cap, and the flap valve all join the atrioventricular cushions normally. They are not. At least on that side. Here's the opposite side. And the defect did extend to become perimembranous up under here. The valves are in fibrous continuity, and they are not really offset in this part at all. There's the VSD here on this anterior component. So our pulmonary outflow tract is here. So a nice straddling and overriding of the tricuspid valve. So I guess I am going to I'll just talk about straddling valves right now, since we're on that subject. Because I have actually more straddling mitral valves, which to me is kind of uncommon, than I do straddling tricuspid valves. We looked at this specimen earlier today with respect to our ventricular septal defects, and we showed that there was a very large inlet muscular ventricular septal defect. So this is part of the interventricular septum. So the defect is here and the defect is here. This patient actually had, I believe, a DKS because there was a double outlet right ventricle, and they had the patient with a Glenn shunt, but then eventually went to transplant. But you can see that this papillary muscle, this group of tendinous cords, and this group of, well, not that one, but right here, behind this portion of the septum, are all straddling and supporting part of the mitral valve within this very hypertrophied right ventricle. But you can see the extent of the VSD. It's all the way around there. And the right ventricle, as I said, has the pulmonary trunk and the aorta supported by complete muscular infundibulums, which are quite hypertrophied as well. And when we look at the mitral valve, you can see where it's straddling the interventricular septum better from the left side than you can from the right. And I will say that when you have a straddling mitral valve, you more often will have a double outlet right ventricle or transposition or discordant ventricular-arterial connections. And I can show you a very rare heart that has concordant ventricular-arterial connections with a straddling mitral valve. Again, Dr. Van Meerop kind of windowed this right ventricle. You can see that the arterial trunks are normally related. So the pulmonary trunk is here. There was a pulmonary artery band, and there is the aorta sitting posterior and leftward, or rightwards, I should say, of the pulmonary trunk. There was juxtaposition of the atrial appendages. So you can see the left appendage was pulled posterior to the arterial pedicle. This is the right appendage. When we look at the tricuspid valve inlet, it's left intact here, supported by this anterior papillary muscle, which is bifid and supporting part of the mitral valve across the crest of the septum. So there are some tendinous cords from the mitral valve and there as well. But there are concordant ventricular arterial connections. This heart is quite impressive from the short axis. So the right appendage was extremely dilated. Here's our tricuspid valve orifice and our separate mitral valve orifice. There's the coronary sinus. And you can see where the interventricular septum is and how the mitral valve is about half and half committed to the right and the left ventricle. Extremely dilated, almost aneurysmal atrial septum in this straddling mitral valve. There's our left appendage with its narrow junction to the left atrial vestibule. So just an interesting case with concordant ventricular arterial connections. This is another straddling mitral valve that is a tiny heart that went to transplant. You can see the very dilated one of the arterial trunks. By the coronaries. I think this dilated component is the aorta because I can see where the coronary was coming right here. Sorry, I'm not looking at the screen. So this very dilated component is the aortic trunk, and this smaller component is the pulmonary trunk. Here is our right atrioventricular junction, or the tricuspid valve, atrial septum at the base of the heart. And when I open the left atrioventricular junction, you can see the anterior leaflet of the mitral valve here and how it's straddling the crest of the ventricular septum, with part of it supported in the left ventricle, or the right ventricle, sorry, and the remaining component supported in the left ventricle. There you can see the crest of the septum. When we look at the right ventricular aspect, here's our tricuspid valve orifice, and here is our straddling component of the mitral valve. And another hallmark of straddling valves is that the straddling tricuspid valve will straddle towards the inlet of the ventricle, whereas the mitral valve will straddle towards the outlet of the ventricle. And the arterial trunks in this case were very unusual, both arising from the right ventricle, but the valvar leaflets were in fibrous continuity with one another as they came off of the ventricular mass. It's hard to see because they've been cut at time of transplant here, but I have a really nice heart to show you with this arrangement when we look at outlets tomorrow in DORV. And this is another heart that went to transplant. And if I open the right ventricle as it was initially dissected in clamshell fashion, you can see the right ventricular inlet here. And here is our straddling mitral valve. So this mitral valve, right up in this area, is adherent to the crest of the septum. So there's essentially no inlet to the left ventricle. It's all coming into the right ventricle because the valve virtually closed off the ventricular septal defect. This heart does have a double outlet right ventricle. You can see both outlets supported by complete muscular infundibulums. And when we look at this heart has a double inlet and a double outlet. So when you have a double inlet right ventricle. The tiny rudimentary left ventricle is typically, as Professor Anderson would say, in the hip pocket of the heart. It's posterior inferior. So this is the imperforate component of the mitral valve. And you can see how tiny the left ventricle was. This is where it's adherent to the crest of the septum. And there are a couple of tendinous cords that remain in this tiny left ventricle. So it is indeed in the hip pocket of the heart, whereas when you have a double inlet left ventricle, you have the hypoplastic right ventricle on the anterior superior or the shoulder of the heart. Just a couple of differences in where the ventricles are located depending on what you're seeing relative to the inlets. Let me rearrange here a little bit. Everybody is starting to dry out just a little bit. Going all day.
And maybe we could take, while you're doing that, we got a question from the chat. Came in from Dr. Mayhew. Seems like this is a question from a place of pain, put there by our surgeon. And I quote, I might have missed this in the introduction to inlets, but as a fellow, I often struggle to know when it's appropriate to use the term left AV valve versus mitral valve when it's not a complete AVSD. Could you clarify? Would you suggest that even an isolated primum ASD is on the endocardial cushion defect spectrum, and therefore the AV valve should be referred to as left and right versus mitral and tricuspid?
Correct. It's a common AV junction. Even if they're separate right and left orifices, it still has the same anatomy as a common atrioventricular. The bridging leaflets are adherent to one another, giving you separate right and separate left orifices. Whether one's hypoplastic or not, it's still a common AV junction. So it's not, when they're adherent to one another, it's not a primum ASD. It's an atrioventricular septal defect with separate right and left. So it's not a mitral valve, and as Professor Anderson would say, it can never become a mitral valve. And so it's left AV valve and right AV valve. Is that good? So I actually forgot to show one of my mitral valve parts, but it's going to be a good tie-in with what I want to, where I want to go to next.
Just so the audience. Here we're doing something.
Can you put it on this side?
Yeah.
Because it's going to be in my way.
Can I run this through yours?
Okay, thanks. All right, so this is one of those rare cases that we'll look at again when we talk about functionally univentricular hearts, but it's the only case I have that has a double orifice mitral valve. So we'll just double dip with this specimen. Plus, it's a good lead in to my tricuspid valve issues. So here, this was an explant. So you can see that there was a morphologically right atrial appendage. Here's the mouth of our coronary sinus. I believe this patient had a Fontan. So you can see all these sutures here. I can't remember what type it was. And when we look at the floor of the right atrium, you can see it's blind ending. So there was tricuspid valve atresia. When we open up this specimen and look at the inferior aspect, you can see that there is no potential for a right atrioventricular connection. All this fiber fatty tissue is between the floor of the right atrium and the top of the right ventricle. So this is essentially that inferior pyramidal space. And when you look at the embryologic issues that Professor Anderson explained about expansion of the right atrioventricular junction so that you could have a right and a left atrioventricular communication or separate inlets to the right and left ventricles, this results from failure of that right atrioventricular junction to expand. So no potential for a connection. And you can see that if we put a pin in the dimple in the floor of this right atrium, it usually will point towards the left ventricle, telling us that that is what happened, that there was failure of the right atrioventricular junction to expand. And you can explain a lot of things by that one embryologic failure. So if I can just go off on a little bit of a tangent, actually, maybe I'll wait to explain that tangent when we talk about functionally univentricular hearts. So the point I need to make here is that there is no potential for a right atrial to right ventricular chambers. And like Professor Anderson said, they are aligned with one another, but there's no potential for a connection. So we can see here that there was a large mitral valve. And this is one of those rare hearts that has a uniatrial but biventricular connection. And that's because we have straddling of the mitral valve. So this is the crest of the interventricular septum, coarsely trabeculated right ventricle, and fine crisscrossing left apical trabeculations. The thing that differs in this heart from a classical tricuspid valve atresia is that the right ventricle is not at all hypoplastic. It pretty much reaches the apex. And that's because of the straddling and overriding of the mitral valve. So both ventricles were getting good flow so that it could grow. And you can see the dysplastic nature of this mitral valve and where it was straddling the septum in part here. And if we look at the opposite aspect, looking from the spine towards the sternum, so this is the tip of the right appendage, the left atrial vestibule here. You can see they did do some surgery on the mitral valve, and you can see a papillary muscle within the right ventricle from the apex supporting a portion of the mitral valve, as well as a number of tendinous cords attached to the crest of the septum. And this is the area where there is a double orifice. Again, it's not an artifact, because if I lift this up, I can show you the tendinous cords and little papillary muscles supporting that separate orifice. So I'm sorry that I don't have a normal heart with a double orifice mitral valve, but this is as close as I can get with what I have. So just nice to show that there is no potential for an atrioventricular connection. And that will move me into showing this little heart that we looked at earlier. Actually, I want to look this side. And get the two same sides, both inferior aspects here. So this case also has tricuspid valve atresia, but it's because the valve is imperforate. So if this right ventricle was big enough, they could possibly connect the right atrium to the right ventricle. In this case, it's extremely tiny, but you can see the diaphragm of valvar tissue here. The difference between these two is no muscular connection potential between the right atrium and the right ventricle. Here, the right atrial wall is connected in normal fashion at the atrioventricular junction to the right ventricular myocardium. So there is a potential for a connection here in this type of tricuspid valve atresia or imperforate tricuspid valve, whereas in the classical type of tricuspid atresia, there's no potential for a connection. So these are just two nice hearts to show side by side that they both are tricuspid atresia, but they differ in a couple of ways. So. Yeah, it is. So there is one group here, multiple connections to the interventricular septum, and then there is the other papillary muscle within the right ventricle. So some of these tendinous cords have been cut from this papillary muscle. And then you see this other conglomerate of papillary muscles that are supporting part of this leaflet here and part of the second smaller orifice. No, because there is failure of expansion of the right atrioventricular junction. If this would have expanded to some extent, you would have had a common AV valve with an unbalanced connection. And I have actually had that question in the past. So now that we've talked a little bit about some of the straddling issues and the difference between the types of tricuspid valve atresia, I'm going to go back to one of my normal hearts. And let's look a little bit at the normal architecture of our common AV valves. Or, sorry, of our normal AV valves, I should say. So while you guys were looking at some hearts, there were some comments about the support of the tendinous cords relative to the atrioventricular valves. So the tricuspid valve has both papillary muscle and septal attachments. And these septal attachments can attach to these little papillary muscle heads on the septum. They can attach directly to the septum. And as I mentioned when we talked about the normal heart, there are 3 leaflets. So the septal leaflet lies against the septum. This is part of the inferior leaflet. And you can see that some of these tendinous cords go up under here at the base of the leaflet. Some may attach to the middle or the belly of the leaflet. And these are the tendinous cords that are attaching to the free edge of the leaflet. And the inferior papillary muscles can vary quite a bit. You can have multiple small ones or a solitary one. They can be hypoplastic. They can be quite large. The medial papillary muscle supports the commissure between the anterior superior and the septal leaflet. And the anterior papillary muscle is the largest of the 3 papillary muscle groups in the right ventricle. You can see that the anterior superior leaflet is here, and this is part of the inferior leaflet. So you have these tendinous cords arising from the anterior papillary muscle and supporting the edges of those 2 leaflets. It's not always easy to look up underneath the anterior superior leaflet, but you can see that there are some tendinous cords attaching to the belly of the leaflet here, and they are just extra support, kind of similar to what we call the strut cords relative to the mitral valve. And when we look at the mitral valve,
I hope this is the heart that has the good basal cord. Maybe not, though. So we talked about the mitral valve being equally supportive of or from both of the papillary muscle groups. So you can see from this papillary muscle, we have cords to the edge of the anterior leaflet or the aortic leaflet, and same from this papillary muscle group. And they also are supporting the mural leaflet and the mural leaflet here. When we look up under the valve, there are sometimes cords that are attaching up here to the base of the leaflet. And I have one heart that has a really nice little papillary muscle up under there. And apparently this isn't it, but you can see some of these cords that are extending up on to the base of the leaflet rather than at the edge of the leaflet. And those are the basal cords. The strut cords are these cords that are typically a bit thicker, and they extend on to the belly of the anterior leaflet, and they are very supportive cords to this very broad leaflet. So there can be all kinds of variations in the chordal support of the mitral valve. You can have fusion of these tendinous cords, and I have a couple of arcade malformations, some of which we'll see in the hypoplastic left heart group, which are very nice. And I think I have one today that has both an arcade and a hammock type of arrangement. So variations in the mitral valve annulus and in the support of the cords can cause a number of issues. So I will first go to tricuspid valve issues. And I have a number of hearts here that have polyvalvar dysplasia. And dysplasia can range in or show itself in many different ways. So this is a recent case that when we look at it from the outside, it shows us almost similar anatomy to what we see in an Epstein malformation. And this is what we call at autopsy what would be a wall-to-wall heart, so that the right atrial border would touch the right chest wall and the apex would touch the left chest wall. So very dilated right atrium, almost looks as big as the ventricular mass. And this particular specimen has tricuspid valve dysplasia. We'll look at the mitral valve and see if it is dysplastic as well. But you can see that the valvar leaflets are curtain-like. And the anterior superior leaflet and the inferior leaflet are totally normally hinged from the hinge point or the atrioventricular junction, whereas the septal leaflet of the tricuspid valve has certain areas that have failed to delaminate. I can't get my probe up under there. So this would be called a micro-Epstein malformation, where the valve has failed to delaminate from the septal surface, but very dysplastic, almost curtain-like valve with this nodular excrescences on the edge. We all know that tricuspid valve dysplasia is part and parcel of what we see in Epstein malformation as well. In this specimen, we have pulmonary valve atresia. So when you have pulmonary valve atresia and tricuspid valve dysplasia, that is one of the things that show us this wall-to-wall heart. Looking at the mitral valve, It is mildly dysplastic. With a few little thickened nodular areas on the edge, but you can see that the left ventricle looks tiny compared to the very dilated right ventricle. And you can see it doesn't yet reach the apex. The coronaries outline the septum. And the aortic valve was not dysplastic. So this was just a dysplastic pulmonary or tricuspid valve with pulmonary atresia and an intact ventricular septum, showing us the typical anatomy we see of the wall-to-wall heart. This is a recent case that I had. You can see that the flap valve is a little bit deficient within the atrium here. There's the superior cable vein, inferior cable vein, and eustachian valve. And this is the mouth of the coronary sinus. So this case had polyvalvar dysplasia. I believe this was from a trisomy 18 autopsy, and you can see how nodular and thickened this valve is all the way around. Some of the papillary muscles are fused directly to the edge of the valvar leaflets here and very fused in some areas. So also a ventricular septal defect and a cleft at the zone of apposition between the anterior superior and the septal leaflet. So this was the case that I kind of showed you how you could get left ventricular to right atrial shunting with this deficient area in the tricuspid valve. And we looked at 100 normal hearts or so-called normal hearts, I don't know, maybe 10 years ago or something, and we decided that there was no such thing as a normal tricuspid valve because there were so many different papillary muscle combinations and valvar sizes of the valvar leaflets, and it was just such a much more variable valve than was the mitral valve. This case also had pulmonary valve dysplasia. You can see how nodular this pulmonary valve was. There were even these cauliflower-like excrescences extending into the sinus. And it's amazing that I just did a trisomy 18 autopsy and it had the exact same anatomy with this cauliflower-like protrusion laying in the valvar sinus. So these valves can have a good-sized annulus, but they can be stenotic secondary to the bulk of the valvar tissue. The mitral valve as well was extremely dysplastic, very nodular. And if you guys have a chance to look at some of these, you can feel how firm this valvar tissue is. It just almost looks like cauliflower. And the aortic valve, I think, was the least dysplastic in this case, but you can see there was some thickening. And there is that little ventricular septal defect with some of the valvar tissue coming through the defect. And in cases where this is extensive, that can also be an obstructive component to left ventricular outflow tract obstruction, where this valvar tissue extends through the defect and causes some subaortic stenosis. So a lot of different things that can arise when you have polyvalvar dysplasia. This is a case that had pulmonary stenosis and intact septum. So already you can see that there was a repair or an augmentation of the right ventricular outflow tract. You can see the anterior interventricular coronary. And look at the apex of the right ventricle. It's a bifid apex. So if I would look at this heart, of course, without the repair, I would suspect that there was going to be some type of right ventricular hypoplasia just because of where the coronaries were located and what the apex looked like. When we look inside of the right atrium, this is one of those cases that had a prominent eustachian valve. So you can see it's partially dividing the right atrium. So the atrioventricular valvar component was separate from the venous component. So here's the superior cable vein. There is the inferior cable vein. So if that eustachian valve was more prominent, it would have totally divided this right atrium. There you can see a deficient flap valve. And behind this prominent eustachian valve, there's another vestibular atrial septal defect. That's the mouth of the coronary sinus. So the interesting thing about this hypoplastic right ventricle with an intact ventricular septum is that the tricuspid valve was extremely dysplastic. And you can see that it formed a windsock type of malformation that was extending up into the pulmonary outflow tract. So most likely one reason for subpulmonary stenosis or pulmonary valvar stenosis with this dysplastic valvar tissue creating this windsock that was going out the right ventricular outflow tract. So yet one other abnormality that tricuspid valve dysplasia can lead us to, these windsock malformations. The left ventricle, I believe, was okay. Well, there was some mitral valve dysplasia in this heart as well, with a tear, an artifactual tear in the mitral valve. So one other thing that can give us valvar dysplasia are cases that have certain syndromes, and this particular case had Marfan syndrome. And I have another heart in my collection that you would think they were the exact same hearts. They look so similar as far as the valvar anatomy. You can see there is tricuspid valve dysplasia. There was some regurg. You can see the doming of this valve up across the atrioventricular junction. So there was tricuspid valve regurgitation, and there was quite a large membranous septum in this specimen with almost like a cleft in the myocardium up to that region. The pulmonary trunk and the pulmonary valve were also very malformed. You can see all these fenestrations at the edges of the leaflet where they extend up to the sinutubular junction with very poor interleaflet triangles. And the mitral valve also shows us evidence of prolapse with these dome-shaped areas bulging above the hinge point and very hypoplastic papillary muscles, that their heads are very close to the apex and almost joining from the same complex. Very long flailing cords. You can see they're not very taut, they're very loose. Most likely the reason for this pulmonary, the prolapse of the mitral valve, not pulmonary, but very dysplastic, thickened valvar leaflets. And the aortic valve also shows us very dilated valvar sinuses and poor interleaflet triangles between the leaflets. So valvar dysplasia doesn't always come by itself. This specimen we looked at with our atrial septal defects and just shows us another heart with mitral valve dysplasia. This is a bit more mild, but you can still see very thickened tendinous cords that are fused directly to the papillary muscles. So some degree of mitral stenosis, because you can see there was a very hypertrophied left ventricle. And I think this case had bifoliate aortic valve, but it's kind of hard to see on the short axis. So mitral valve dysplasia can also cause stenosis at the annular level and at the lower portion of the inlet or the inflow of the left ventricle. This case is actually very difficult to open because the mitral valve annulus itself was stenotic and the papillary muscles are very thin and short. And you can see how the tendinous cords are virtually fused to one another. So this is somewhat consistent with an arcade malformation where the papillary muscles are fused to the edge of the valvar leaflet and the tendinous cords are fused to one another as well. And this had a very dilated left ventricle, very poor inflow to this left ventricle. There was actually some clot or thrombus within the left ventricle, severe endocardial fibrinoelastosis. You can see how you can almost peel this off in some instances, but very much caused by the turbulence within this left ventricle. And the aortic valve itself was unicuspid and unicommissural with only one complete interleaflet triangle that was right here. You can see there's an incomplete interleaflet triangle with a raphe there, and the second one is right here. So you can see those two raphe in there, one here and one here, with the only interleaflet triangle that's intact is here. And that typically is the interleaflet triangle that's associated with the aorta to mitral fibrous continuity and between the non and left coronary valvar sinuses. This is another case that went to transplant, and I didn't open across the mitral valve because when I opened the left ventricle, it just showed the pathology so nice. But you can see the left atrial vestibule has very thick endocardial fibrinoelastosis, and the mitral valve is extremely thickened and stenotic as we look into the atrioventricular junction. You can see how thick this left ventricle is. And look at that endocardial fibrinoelastosis. So a lot of turbulence going on in this ventricle. And this aortic valve as well had a cuspid unicommissural arrangement and was quite dysplastic. When we look at the mitral valve, the opening is here. So it's extremely stenotic. You can see that the papillary muscles are very close to one another, and there is a fibromuscular bridge between them here where the tendinous cords are fused to the tip of the papillary muscles and to one another in around most of the valve. So this is consistent with an arcade and even the hammock malformation where you have that fibromuscular bridge between the papillary muscles and all these fused tendinous cords. So my last mitral valve issue will lead me to Epstein malformation. So here we have a short axis. This was a transplant case as well. There's our aortic valve and the pulmonary valve. And when we look at the mitral valve orifice, this was an artifact cut at the time of transplantation. So this mitral valve hinge point was in its normal position, but you can see the extensive curtain-like dysplasia of this mitral valve, and it was totally fused to the free wall in most of this area, with the only way out the aorta up under this thickened component of the mitral valve. Well, it's even hard to get out, so there we go. So very adherent mitral valve to both the septal and the free wall. And you can see how that aortic valve was stenotic because there was very poor flow getting out of that aortic valve. It also, I think, is exhibiting a unicuspid unicommissural arrangement with a raphe there and a raphe here, and the only interleaflet triangle here between the non and the left coronary valvar sinuses. There's the right coronary. One raphe there, one right here. So mitral valve dysplasia and mitral valve abnormalities, as well as tricuspid valve dysplasia, have a wide range of things we can see. I'm going to move on to talk a little bit about Epstein malformation. Oh, actually, before I do that, I have a plastinated specimen here. Dr. Van Meerop plastinated a number of his hearts, and so we can handle these without gloves on. This specimen had, I believe, tetralogy of Fallot. So there is a subaortic ventricular septal defect, subpulmonary stenosis, tiny pulmonary trunk, and a bigger aorta. The only thing is I can't really open these in the same fashion I can a formalin-fixed heart, but this shows really nicely a parachute mitral valve. So you can see this solitary hypoplastic papillary muscle with the tendinous cords all going to that one papillary muscle, and this very funnel-like mitral valve orifice. So you can picture this papillary muscle conglomerate right here. It has two little heads as being the man at the end of the parachute. And there are the strings attached to the parachute. And this is what will bring him down to earth. So you can see that nice funnel shape that you typically see when you have severe stenosis associated with a parachute mitral valve. So just a nice example. I almost forgot to show you guys. So if we move on to talk about Epstein malformation, when we think about this, and I don't have a PowerPoint to show you this, but it used to be talked about as this having a downward displacement of the mitral valve. And a lot of cases were looked at to assess this. And it's actually failure of the tricuspid valve to delaminate from the ventricular septum during development, but it's not really a downward displacement. This one kind of looks like that, but as we progress through these Epstein malformations, it actually is a rotation of the hinge point towards the outflow tract. And the Epsteinoid involvement is typically with the inferior and the septal leaflets of the tricuspid valve. The anterior superior leaflet can be involved in some cases, as we mentioned. The valve can be dysplastic in association with Epstein malformation, but typically the hinge point of the anterior superior leaflet is not affected, although I do have one heart that was or is affected. You can see the atrioventricular junction here. There's where the hinge point of the tricuspid valve should be, and you can mark this where the atrial myocardium joins the ventricular myocardium. So this is definitely displaced, albeit just a small epsteinoid malformation or an Epstein malformation with no atrialization of this little ventricular component. So this is a very mild Epstein malformation. Sometimes with Epstein malformation, you can have increased trabeculation of the apical trabeculations within the left ventricle. This one does not show that. And the pulmonary valve is widely patent in this case. So when we look at these malformations as we look towards the outlet, there will be many different attachments of the epsteinoid components as they cross the outlet. You can have hyphenated attachments, you can have curtain-like attachments, and you can have very little valve tissue at all in some cases. And even in some cases, as we saw with the atrioventricular septal defect that was unbalanced and left dominant, you can have the valvar leaflets totally separating the inlet from the outlet and the apical trabecular component within the right ventricle. So that's a very mild Epstein malformation. This one is getting a bit more severe, and we can see that there is an associated atrial septal defect or a deficiency of the primary atrial septum. Here's our eustachian valve, and you can also appreciate that this was a wall-to-wall heart, so very dilated right atrium. There is the mouth of our coronary sinus. Right here. It actually is above the eustachian valve. In most cases, it's beneath it or below it. I apologize for the dark color of this ventricle. Probably had the blood in here for a long time before I got to look at the heart. And you can see where the hinge point of the tricuspid valve should be here. There is the atrioventricular junction. You can see the fibrofatty tissue at that junction here. So very little atrialization in this right ventricle, but you can see a little bit more severe delamination, failure to delaminate of the tricuspid valve here, and a little more of an appreciation how the valvar orifice is more directed towards the outlet. The anterior superior leaflet has its normal hinge point, but is extremely dysplastic and fused to the tips of the papillary muscles. And when we look at the outflow, this shows us some of those hyphenated attachments you can get of the valvar leaflet between the inlet and the outlet. So you can get hyphenated attachments. And this is septal leaflet. So you can see how it's rotated towards the outlet of the right ventricle. I have a nice 4-chamber cut of an Epstein malformation. And actually, this came to us from the medical examiner's office, and it was opened, but I glued it back together and cut it in a 4-chamber plane. So here we can see a prominent eustachian valve, pectinated right atrial appendage, smooth left atrial vestibule. So there's the primary atrial septum with a small deficiency and the atrial buttress. And here you can see the septal leaflet of the tricuspid valve and the inferior leaflet completely plastered down to the right ventricle. So failure of the inferior and the septal leaflet to delaminate from the right ventricle. Only a small component over here towards the diaphragmatic aspect. So a lot of times you'll have a tongue of tissue that will go from the inferior leaflet to the anterior superior leaflet. And you can also see how this septal surface may have started to have a little bit of atrialization because it's dilated towards the left ventricle. And when we look at the opposite aspect, so from the spine towards the sternum, you can again see that septal leaflet plastered to the septal surface. And here is that tongue of tissue that we saw on this opposite aspect right here that is communicating across the ventricular cavity to the anterior superior leaflet. So you can see how the hinge point or the hinge line of the tricuspid valve was rotated towards the outlet. So there's its hinge line here. And there is the outlet to the right ventricle. So this is what some people may refer to as the keyhole opening to the outlet, so that the tricuspid valve now, with the leading edge of the septal leaflet and the leading edge of the anterior superior leaflet, forms more of a bifoliate coaptation zone than a normal tricuspid valve. So you can see that this septal or this anterior superior leaflet was causing almost like a curtain-like division between the inlet and the outlet of the right ventricle. So this is the so-called keyhole. And when we look at the outflow tract, you can now appreciate the bifoliate nature of where the septal leaflet is coapting with the edge of the anterior superior leaflet, and how that attachment of the anterior superior leaflet creates that curtain between the inlet and the outlet of this right ventricle. So just a nice four-chamber view of an Epstein malformation. This is a really nice specimen, actually came to us as well from the medical examiner's office, I think from a 5-year-old who died suddenly. So this was undiagnosed. You can see that there was, and obviously this was a number of years ago, so there was a small deficiency at the flap valve at the floor of the oval fossa. Here is our coronary sinus, and you can see that there is quite a bit of atrialization of this inferior wall of the right ventricle. So the hinge line of the tricuspid valve should be here. You can see the right coronary artery in the atrioventricular groove. So this is the atrioventricular junction. Quite a bit of atrialization, as I mentioned, of the right ventricle. And this heart shows really nicely the bifoliate nature of how the tricuspid valve now coapts with the leading edge of the leaflet. So this hinge point is rotated towards the outlet rather than downward displacement. And you can see that there is very little left of the septal leaflet on the septum, just these few little nodular edges. And here is that typical tongue of tissue between what's left of the inferior leaflet and the anterior superior leaflet. This specimen did have some malposition of the anterior superior leaflet. You can see part of it is still fused to the free wall of the right ventricle. So this one had more involvement of the anterior superior leaflet than what we normally see. When we look at the outlet, this shows us nicely, again, that curtain-like attachments of the anterior superior leaflet with some hyphenated areas down here towards the apex, and quite a bit of dysplasia there is so-called keyhole where this little edge of the septal leaflet is coapting with this edge of the anterior superior leaflet. The pulmonary outlet isn't all that stenotic. And when we look at this left ventricle, it does show us in this particular heart that there was an area of increased trabeculation within the apical trabecular component, so that the bottom 1/3 of this ventricle is compromised by these retention or increased trabeculations. Yeah. Yeah. And apparently undiagnosed. The medical examiner just sent it to us at Tampa General. So I don't know much other than that. But at least they were cognizant enough to send it to us, because they don't always know what they're looking at. The pathologist I work for is boarded both in forensics and in pediatrics. So they often send her cases because like I said, this was probably maybe 15 years ago too. So I can't remember either. Yeah, probably. You mean through the small ASD? Yeah. Yeah, I tend to think that some of these patients do have arrhythmias, so that may have been the case. But, you know, one of the things I question is, who was this kid's pediatrician that this was missed? Or were they a family who didn't believe in physician? So you can't always accuse the physician. Let me just put that disclaimer out there, because sometimes it's the family who doesn't want any intervention or treatment. So I have a really severe Epstein malformation. These don't typically go to transplant, but this one did. You can see that the only remnant of the septal and the inferior leaflets are these trabeculated structures that are going across the ventricular chamber, so that the hinge point of the tricuspid valve should be here. And this is the atrioventricular junction. You can see how thin-walled this entire right ventricle is. Here is the apex. And there's those hyphenated attachments between the septal and inferior and anterior leaflets, which there is even a little, this is the orifice to go out the pulmonary outflow tract, so that this is part of the septal leaflet here, and there is anterior superior leaflet here, and that tongue of tissue between the two. When we look at the outlet, you can see that there was that small little keyhole and not much of an outlet component to this right ventricle. So a very extreme Epstein malformation that went to transplant, because you can see how thin-walled this entire right ventricle is, all the way around the apex. I have a case here that again has a pretty severe Epstein malformation. This heart was not opened in a very good fashion, so I've kind of sewed it back together here. You can see the atrialized component of the inferior wall that was kind of cut through. And this shows nicely how the hinge point of the tricuspid valve has rotated towards the outlet. So there's the edge of the septal leaflet. Here is that tongue of tissue between the inferior leaflet and the anterior superior leaflet. And you can see nicely how this valve closes in bifoliate fashion now, secondary to the failure of that valve to delaminate and the actual rotation of the hinge point towards the outlet. And this case also had a perimembranous ventricular septal defect. So here's the septal leaflet. Here's the anterior superior leaflet. You can see some of those hyphenated attachments. And there is, excuse me, the perimembranous ventricular septal defect. I have one case that has a mid-muscular septal defect that was closed by the septal component of the tricuspid valve, and there was just a little bubble in the septal surface where the blood was trying to get through. But it was a very large heart, and I couldn't see fit to bring it with me. This specimen had mitral valve stenosis and aortic atresia. So very unusual combination of defects. The last heart that I have to show you in this group of Epstein malformation, you can see has a very dilated right atrium. Looking into this dilated and hypertrophied right atrium, there is the oval fossa, which is kind of pushed leftward. There's the superior caval vein, and the mouth of the coronary sinus is here. So this Epstein malformation actually closed off the majority of the right atrioventricular communication. This is a little bit of an artifact where it was imperforate. And you could see this is a portion of the right ventricle that was atrialized. And it was totally separated from this component, which leads us toward the outlet. So this is the subpulmonary infundibulum, so that this specimen also had pulmonary atresia. And you can see there was a ventricular septal defect that was closed off by the tricuspid valve here. That is the aorta there. So a very severe Epstein malformation that became adherent to the crest of the septum, where it closed the ventricular septal defect and also separated the apical trabecular component from the outlet component. You can see those couple little tendinous cords there. That's the artifact where the valve was perforated by handling. And so a very severe Epstein malformation where the valve totally blocked the inlet to the apical trabecular component and the outflow and closed a VSD as well. And you can see how the left ventricle almost looks like it has increased trabeculations. Yeah, the atrial septum is actually pushed a little bit leftward. So there's the superior caval vein. There is the atrial septum. So there's a prominent, actually, fold in this particular specimen, and there was a small deficiency of the flap valve just here. So quite unusual specimen. So what time is it? 4:45. Is that right? Okay, so I didn't have my timer set very well, so I'm sorry if I went long. But I hope that gave you guys a sense of all the different stuff you can see at the right and left atrioventricular inlets, as well as atrioventricular septal defects. If there's anything else you want to see, I can show it to you again.
Believe the Epstein anomaly falls in a spectrum of dysplastic RV, like there's parchment right ventricle, like Ewell's anomaly on one end, and then arrhythmogenic right ventricular dysplasia. So do you think these are all related anomalies?
I don't know that I can answer that question. All I can say is that I have not seen any cases of arrhythmogenic right ventricular hypoplasia or where there's not much muscle or any muscle. The cases I have seen that they thought were Olds anomaly have turned out to have a few myocardial fibers between the endocardium and the epicardium, and so it won't fit into that classification. But the one case that I do have access to has a very stenotic tricuspid valve that's not that abnormally formed. Maybe some fused tendinous cords, but a stenotic annulus or hinge point, if you will, and a very dilated right ventricle. And they thought it was Olds anomaly in utero, but we disproved that. I mean, I can see muscle, Frank, grossly. So I don't know if they are related. I can't really answer your question. We can maybe ask Professor Anderson at some session tomorrow. But I don't know that I've heard that association either in the past.
Final question is, how often do you see, or is there any such described entity on the mitral valve? I know you did show an example where the mitral valve was plastered, but why do you think it's that much more uncommon on the left side? As you're seeing early stage fetuses, do you actually notice this in the early stage? So that's why they don't make it to infancy.
I haven't seen many fetuses that showed that Epstein-like malformation in the mitral valve, like I showed today. And I think the mitral valve forms separately or differently than the tricuspid valve, so that the mitral valve is formed from the cushions themselves that are not affiliated with the septum, whereas the tricuspid valve actually has to lift off of the septum during development. So I think there are two different developmental aspects or precursors why you don't see so much like an Epstein malformation in the mitral valve. It's septophobic, so it forms away from the septum. So it never undergoes that actual delamination that the tricuspid valve does.
Question about supravalvular mitral stenosis. We see it not uncommonly from an imaging perspective, but my sense is there's a range of pathologic mechanisms. What is that spectrum you see on your end?
And actually, you just reminded me that I forgot to cross-list one of the specimens I have for tomorrow. So I do have a partial supravalvular ridge to show you in a heart that has transposition. So I'm sorry, what was your question again?
Oh, just I think there's a lot of mechanisms for that phenomenon that we see through imaging. From your standpoint, what are some of the examples that create that same phenomenon? So for example, you mentioned one of the hearts had fibroelastosis of the mitral orifice. What are some others?
I am not really sure how supravalvular mitral rings occur. I know we see them in Schoen syndrome, And I know they can be partial, they can be complete, and I know they can be supravalvar and intravalvar. But I'm not really sure about the mechanisms of how they occur. But I always learn from these sessions too. And then the next time somebody asks me this question, I'll be able to answer it because I'll check with the professor and maybe get an answer. So these sessions are really helpful for me as well, because there are questions I get that I don't know the true answer to.
Any other questions to conclude today? Very good. Well, this was such a wonderful day. Maybe one final round of applause for Ms. Spicer. Thank you to all those who joined us online as well. Tomorrow we have at least 2 more anatomic sessions starting at 7 a.m. For everyone who physically shows up, we're going to be in the School of Nursing tomorrow, not in this room. So check your calendars on that one. And then we have 2 grand rounds, PEDS grand round at noon, and then the Night Cardiovascular Institute ground noon. So we'll look forward to it. See you all then.